And the first session we're going to have is Decoding the Glaucomatous Disc by Dr. Ronnie George, sir.
Yeah, so good afternoon. And so Parthos felt that this is an important topic, and post-lunch, you're not going to be that interested in looking at it. So let's try and cover that in the next few minutes. So the first thing is, whenever you talk about examining the disc, there's no question about, if you don't have anything available to you, a direct is okay, but otherwise it has to be a slit lamp biomicroscopy using a 60, 78 or 90 diopter contact lens or a contact lens. Keep in mind that there are advantages and disadvantages of both, and the best view you get with a 60 diopter lens and the smallest view you get with a 90D, but you can do that with a non-dilated pupil. So one of the three is what you should always use to examine the optic disc. And also keep in mind that whenever you look at the image, you will see an inverted and laterally reversed image. So whatever you are seeing is going to look reversed. There are 5 R's which you can use to remember as to what you need to do with the optic disc. First, observe the scleral ring to identify the limits of the optic disc and the size. Then identify the size of the rim. And this is the rim, not the disc. Identify the retinal nerve fiber layer. Examine the region of parapapillary atrophy, and look for retinal and optic disc hemorrhages. So these are the 5 things that you need to look at in every optic disc. So when you identify the scleral ring, you basically are looking at that ring, exactly what is the margin of the optic disc. And you can actually calculate the disc size, and this is important for you to do because the disc size does have implications for certain diseases and also for the optic, for the cup to disc ratio. And generally, these are the correction factors that you can use in order to measure the disc. So you use the slit lamp and use the little graticule on top to look at the size of the disc, and then you have to multiply it using this correction factor. But these correction factors vary based on whose lens you're using, and these are the correction factors based on different manufacturer's lenses available to you. So a small disc is traditionally labeled as less than 1.5 millimeter area, medium disc 1.5 to 2.5, and a large disc greater than 2.5. And all 3 discs shown here are actually normal, and you can see that they actually look fairly different when you look at them clinically. The reason that size matters is that in an optic disc, the number of ganglion cells doesn't vary very much. It is between 800,000 and 1.2 million, irrespective of the size of the disc. Generally, as the disc size increases, the number of ganglion cells may be a little bit more. But the disc size actually varies much more than this little variation that you get in the number of retinal ganglion cells. And it can vary by a huge amount, and this is data that we're showing you from the Chennai glaucoma study that we did. And you can see here that when the disc area was between 1.5 and 2 millimeters, your mean cup to disc ratio was around 0.2. And when your disc area was 4 millimeters and above, the mean cup to disc ratio was about 0.5. So these are absolutely normal discs, and this is the reason why size matters, because it has a large implication on the vertical cup to disc ratio. And this variability is actually huge. In normal populations, the optic disc size can vary by as much as 8 times. There are very, very few other organs in the body which show this degree of variation, and that's the reason why it is sometimes difficult to distinguish a glaucomatous optic disc from a variation of normal. So the next thing that you need to do is look at the size of the rim. And when you look at the size of the rim, that's a disc margin that you have already marked out, and then you have to identify the cup, or where does the rim actually extend. And what you need to do over here is 2 things. Since this is a stereoscopic view that you're doing, you can actually, if the disc is deep, you can see where it bends. If the disc is not deep, then you have to really follow the vessel. And can you see that this vessel is bending there? And that bend will give you a clue as to that is where the margin of the disc is. So you need to take a slit beam, sweep it across the disc, and assess where it is bending at each time point. And you can mark the cup like that. And the area between the cup and the edge of the disc is obviously the rim. And when you look at the rim, one of the things that we tend to do is, contour is what I asked you to look at, but what we tend to do is we look at the color and we say that's a cup to disc ratio. And if you look at this, looking at it casually, you would say that, yeah, maybe that's what the cup looks like. But if you follow the contour, what you will see is that the contour actually extends all the way there. So that's why it's important not to just take a quick casual look at the disc. Whatever is white in the center is the cup and the rest is the rim. Follow the rim all around and see where the contour is. Next, we'll come to the ISNT rule. For a classical disc, this is what it will look like. The inferior rim will be thicker than the superior rim, which will be thicker than the nasal rim, and the temporal rim will be the thinnest. In general, no part of the optic disc will be thinner than the thinnest part of the temporal rim. So if you see anything anywhere else which is thinner than this, that is likely to be pathological. And this is the ISNT rule. The ISNT rule is true in about 75% of normal eyes. In 25% it's not. But if it is abnormal, you definitely need to look at that disc a little bit more closely. So when you have localized thinning, you can have an incomplete notch like this. So you have localized thinning, and you can see that this part of the disc is actually thinner than any part of the rim, including the temporal part. It is not quite reaching the edge, so it's an incomplete notch or localized thinning of the optic disc. Here you have a complete notch, and a complete notch is when you actually lose all the rim there. So you have a localized complete notch, and you can see there's some nerve fiber layer damage also beyond that. And you can also get concentric thinning like in this disc, where you have almost no rim. There's nothing there, there's nothing here, there's a little bit left nasally, and this can happen typically with very high pressure glaucomas, which have been going on for a while. The next thing that you need to look at when you look at the rim is the cup to disc asymmetry. Is there asymmetry in the cup to disc ratio in both the eyes? And here you can see that both these discs actually look somewhat similar in terms of size, but this has a much larger disc, and you have seen some thinning there, and you also actually have a retinal nerve fiber disc hemorrhage and a nerve fiber layer defect. But it's important that whenever you look at a cup disc asymmetry, you account for changes in disc size. So in this eye, basically this asymmetry in the cup is because of the asymmetry in disc size. And if you put those two together, you can make out that the left disc is actually significantly larger than the right, and that's why there's a cup to disc asymmetry. And you can see a cup to disc asymmetry in up to 8% of eyes, of normal eyes. The next, of course, is pallor. Glaucoma typically doesn't cause pallor unless you have had an acute angle closure or an acute IOP spike, and you can see pallor late after that. If you see pallor like this, so this is a disc which is looking fairly okay, and here you're seeing localized pallor. Even though there's a large cup, the rim is actually fairly healthy beyond the pallor, and this patient actually has a pituitary adenoma, and that's the reason for the pallor, and it's not glaucomatous. And this patient was actually treated for glaucoma for a few years. The third R that you look at, remember, is look at the retinal nerve fiber layer. And how do you look at the retinal nerve fiber layer? So use a red free because that helps you to see it better. So whenever you look with the red free, you have to look for the brightness, you have to look for striations, look for the visibility of peripapillary vessels, and look for diffuse or localized nerve fiber layer loss, which is what is most important. Keep in mind that the brightest zones are superiorly and inferiorly. And the macular area is actually darker because this is where the thickest bundles insert into the optic disc. So it's bright, dark, bright. Always look to see whether there is any change in that. And here you have a nerve fiber layer defect there. You can see this is bright, this is little darker than that, and this area is definitely darker than both sides. So that's a localized wedge defect that you're seeing there. And this is the eye with the superior notch that I showed you before, and you can see a much larger, well-defined wedge-shaped defect, and you can see that this is dark, this is also dark, and this is bright. So the loss of the bright, dark, bright pattern is one of the hallmarks of a localized retinal nerve fiber layer defect. This is one of Jost rules. Jost is probably the most person who's published maybe 400 papers on the optic disc alone. And he has certain rules on how to assess an optic disc. One of them is that all eyes have a localized retinal nerve fiber layer defect until proven otherwise, which means if you don't look for it, you won't find it. And even in this eye, which on a cursory examination looks okay, you can see there is a localized defect. So if you don't look for it, you won't find it. The best way of looking at it is, of course, a red-free photograph, but you can always use the red-free filter in a dilated pupil and assess the retinal nerve fiber layer defect. The fourth R is the region of peripapillary atrophy. And the region of peripapillary atrophy, basically the zone that we're interested in is the beta zone. And here you have greater visibility of the larger choroidal vessels because of exposure of the sclera. And you also have an alpha zone. I'll just show you that a little later. So in this optic disc, this area which is close to the disc is the alpha, and that is demarcated by the green arrows, and the beta zone is demarcated by the yellow arrows. So why this is important is, if you notice the area of parapapillary atrophy, in the area where the disc is looking thin, that is one of the signs of pathology. And if you notice extension, increase in the area of the beta zone with time, that's also indicative that the optic disc is probably progressing. The fifth and the last R is to look for retinal and optic disc hemorrhages. So retinal and optic disc optic disc hemorrhages are not as commonly seen in Indian eyes as you see in some of the East Asian eyes, but it requires careful evaluation, and you don't see it all the time because it disappears within 1 to 3 months, and it can indicate that this eye is showing evidence of glaucomatous progression. It can sometimes be fairly easy to see, but sometimes very, very subtle. So you actually need to take a look at the disc, take a look at it under high magnification, look all around the rim, and you will see it. And sometimes if you take optic disc photographs regularly, you will actually not see it on a picture and not on clinical evaluation. So it's an important thing for you to look at. So which are the critical steps you have? You have the scleral ring, and here you need to look at the size, measure the vertical diameter, or describe the disc as small, medium, or large. Look at the rim. Is the ISNT pattern followed? Is there localized thinning? Is there pallor? So these are things that you will need to comment on each disc. Is there a retinal nerve fiber layer defect? If there is a defect, is it wedge-shaped or is it a slit defect? Is there parapapillary atrophy? Mention it yes or no. Is there alpha? Is there beta? Mention the location. And is there an optic disc hemorrhage? And this is again important. You need to put this down. So if you look at every disc in this pattern, you are unlikely to miss any pathology. So how will you document it? You can write it. Better still, draw it or photograph it. And it makes sense sometimes to look at something like a DDLS scale, which helps you to assess the possibility that that disc of that size with that feature actually has glaucomatous damage. What about the cup to disc ratio? We didn't speak about it at all. And the reason we don't speak about it is, I want you to look at this optic disc. So when we look at it, it's a largish disc, and you can see that the inferior rim is slightly thinner than the superior rim. There is some localized thinning there. There is parapapillary atrophy, a little difficult to comment on the RNFL, and you're seeing an early superior nerve fiber layer defect. And this cup to disc ratio, most of us would put it maybe around 0.8 or something like that. Let's take a look at this disc. This disc is moderate size. Maybe the cup to disc ratio is about 0.6, 0.7. And here what you're seeing is an inferior thinning. You're seeing inferior nerve fiber layer defect, something there superiorly. And you're seeing a denser superior defect and an early nasal defect. So this disc, which actually looks healthier than the previous disc, actually has more of damage because this is a smaller disc than that. And therefore, whatever loss has happened in a smaller area. There is greater RNFL loss here. This is the reason why we don't focus on the cup to disc ratio in isolation. It's very, very important to always qualify it with the disc size. And a careful rim examination is going to give you more information than just a bare cup to disc ratio. And that's what I said. And then to complete, just remember that if you apply these 5 R's to every optic disc, you can actually reliably identify most glaucomatous nerve damage. Thank you.